And now we have Dr. Sandhya Nair. She is the Senior Consultant, Cataract and Uvea Services, Giridhara Institute, and a very experienced surgeon. She'll talk to us about tips to make nucleus management easy and effective. Over to you, Dr. Sandhya.
Thank you, Dr. Soni. After discussing about wound construction and hydro procedures, let's move on to nucleus management. This patient had nuclear sclerosis grade 2 to 3. Pupil was dilating well, and the microscope illumination was reduced to cause minimum discomfort to the patient. After a complete corticocleavage hydrodissection, the nucleus was rotated. You should gently rotate the nucleus so that there is no tug on the ciliary body by the sonules, which can cause pain and discomfort to the patient. Here I prefer to use OVD to moisten the cornea, which can avoid frequent irrigation that can elicit squeezing movement. But you can also try, as Dr. Soni told, the irrigation test. And you can select any strategy of your choice for nucleus management. Here I am using a stop and chop. So once, when you're introducing the phaco probe, do not overinflate the anterior chamber. And when introducing the phaco probe, you should always reduce the infusion pressure so that there is no deepening of anterior chamber, which can cause discomfort to the patient. Here I am using stop and chop. Once around 80% to 90% of the depth of the nucleus is reached, it is cracked into 2 pieces. Globe fixation is not a major problem during nucleus management, because by this time the patient would have got used to the microscope illumination, and we have 2 instruments within the eye to stabilize the globe. Now, during all these maneuvers, care should be taken not to touch the iris, because it can cause intraoperative miosis and discomfort to the patient. Here I am doing vertical chop. The phaco probe was impaled and the right hand was taken up, and the left hand with the Sinskey hook was depressed and taken laterally so that the pieces got separated. Each of these pieces was brought to the anterior chamber and emulsified. And again, before withdrawing the phaco probe, you need to inject OVD so that there is no sudden collapse of the chamber, which can also cause some discomfort to the patient. Endothelium was protected with dispersive OVD and the pieces were emulsified. There are only 2 situations where you fill the anterior chamber completely with OVD in topical phaco. One is before doing rhexis and the other is before IOL implantation. So after nucleus emulsification, again before withdrawing the phaco probe, OVD was injected to prevent sudden collapse of the chamber. Now in this patient, after nucleus emulsification, capsule polishing was done. Sometimes the patients can move their eyes suddenly, so we should be mindful of this. And the irrigation port was kept very close to the posterior capsule so that it is not caught by the aspiration probe. Once capsule polishing was done, anterior chamber was filled with OVD for IOL implantation. Then the patient complained of pain and started moving his eyes. So I thought of giving subconjunctival silocaine. So stretching of conjunctiva can cause severe pain. So you should always anesthetize the area with paracaine dipped cotton buds before injecting, and inject a small volume very slowly so that there is no sudden stretching. Wait for some time and then continue injecting. And after this, using a cotton bud, so the subconjunctival silocaine was taken all around the limbus. So this will anesthetize the conjunctiva all around, and you can operate without causing any discomfort to the patient, and the IOL was implanted. Now here, femto platform was used to create rhexis. You can see there was a small point of attachment that was released carefully, and the flap was taken out. After a careful hydrodissection, as you can see, the nucleus was very soft here, so it was flipped into the anterior chamber and carefully emulsified in the supracapsular plane. This was another patient with soft cataract where the nucleus was prolapsed into the anterior chamber and emulsification was done in the anterior chamber. During this, we need to protect the endothelium with dispersive OVD. And this can prevent unnecessary manipulations during nucleus management and can cause less discomfort to the patient, especially when they are operated under topical anesthesia. This patient had a mature hard cataract, but he was on medicated stent. So the cardiologist didn't want to stop antiplatelets. So I thought of doing surgery under topical anesthesia. So after rhexis, hydrodissection was done carefully so that there was no increase in back pressure. So first a trench was made and then the nucleus was chopped. So the trench was not of enough depth. So this central disc-like nucleus piece came there. So that need to be emulsified first. Otherwise, it will prevent bringing other pieces into the anterior chamber. Again, the nucleus was sub-chopped, but as you can see here, the posterior plate was not cracked properly. So there was that point of attachment. So I trimmed the nucleus piece just above the attachment and then emulsified. During this time, the second half turned on its own. So as you can see, that central point of attachment here, this has to be broken first, after which the pieces will easily come to the probe and it can be emulsified. Now here horizontal chopping was done. So you can see the red reflex there. Once this is seen, you should stop sculpting and then split the nucleus into two pieces. And then the phaco probe was impaled in the nucleus. Sinski hook was taken under the rhexis margin and the equator was hooked, and then this is brought to the phaco probe to separate the pieces. So the Sinski hook was taken under the rhexis margin, up to the equator, it was hooked and then brought to the probe and then separated laterally. So this was a very young patient, very high myope, and then it is better to operate these patients under topical anesthesia because of increased risk of globe perforation in these long eyes with thin sclera. So pupillary dilatation was not adequate, so intracameral phenocin plus was used. Capsulorhexis is being done. Clear colon incision was made, and the patient was very young and the cataract was soft, so it was prolapsed into the anterior chamber. And this patient had an axial length of around 35.34 millimeter, and the intraocular lens power was -1 diopter. So once the nucleus was prolapsed into the anterior chamber, as you can see here, when it was emulsified, there was sudden dilatation of pupil and the anterior chamber became very deep because of the reverse pupillary block that is caused by the 360-degree attachment of iris to the capsule, which is known as lens iris diaphragm retropulsion syndrome. So this can stretch the ciliary body and can cause severe discomfort to the patient, and this happens because of the low scleral rigidity in high myopes. So what you need to do is, we need to reduce the infusion pressure. You can see here, once the infusion was out, the pupil came back to the normal size. So this LRDS can happen at any stage. So what you have to do is, you can also lift the iris off the anterior capsule so that the fluid equilibrates between the anterior and posterior chamber. So here I am using an expand series lens that is +1 diopter because I didn't want to leave the patient hypermetrope at the end of the surgery. So here femto platform was used. So chop pattern with 6 cuts were made. So you can see the bubbles that are trapped under the nucleus. So a hydrodissection was not attempted in the first place. Instead, a small trench was made, and during splitting the nucleus, all the bubbles that were trapped under the nucleus, they got released. And after this, you can do a hydrodissection in a safer way. So a gentle hydrodissection was done, OVD was injected, and the nucleus was rotated. Then these pieces were separated along the area of the laser cut. So you have to hold the piece and just separate it laterally where the cut was made by the laser. And then this piece was brought to the anterior chamber and emulsified as a normal phacoemulsification. So in this patient, pupillary dilatation was moderate. The patient was not on tamsulosin, so I was not expecting intraoperative floppy iris syndrome. So I operated this patient under topical anesthesia. So after removing the capsule flap, so hydrodissection was done. Then you can see there was some billowing of iris. So it is during hydrodissection that the cascade of the events of IFI starts. And then after nucleus rotation, so when the infusion started, you can see there was fluttering of iris and there was progressive intraoperative meiosis. And the iris started to come out through the side port where the Sinski hook was present. So at this point, I reduced the infusion pressure and the aspiration flow rate, so there was less turbulence in the chamber and it became stable, and the iris fluttering and the iris prolapse came down. So after this, the piece was sub-chopped and then OVD was injected. So never overinflate the chamber because it can cause iris prolapse, and protect the endothelium with dispersive OVD because you are working close to the endothelium, because you are emulsifying above the plane of the iris. Because if you emulsify it below the plane, then the fluid wave will go behind the iris and lift it up. Even during cortex aspiration, you have to reduce the aspiration flow rate, and at the end, the IOL was inserted. So to summarize, avoid operating very hard and intumescent mature cataracts under topical anesthesia. Good hydrodissection and slow and careful rotation of the nucleus is needed. Underfill the chamber with OVD and lower the infusion pressure while introducing the phaco probe. Care should be taken not to engage or touch the iris. Use OVD to moisten the cornea. Avoid sudden collapse of chamber while withdrawing the phaco probe, and glow fixation is less of a problem during nucleus management compared to beginning of surgery, and you should be prepared with strategies to deal with any unanticipated problems that can arise during the surgery.